Good morning and welcome to Day 4 of the Pharmacotherapy Preparatory Review and Recertification course. My name is Curtis Smith and I'm a professor of pharmacy practice at Ferris State University, and I was introduced yesterday, so I won't go through all those details and we'll just get started. Also, as with yesterday, for this particular talk, I have no conflicts of interests. The learning objectives are noted in your book, and again, we're starting Book 2 this morning, so hopefully you brought Book 2 and not Book 1. And we'll be in the first chapter, the first two chapters, these next 2 hours of Book 2. The objectives are listed there on the top of page 2 for this particular chapter on infectious diseases, and you can read through those on your own. I will go through a number of topics. It's a very quick lecture through the various infectious diseases, and I don't cover everything. I have to skip through a lot, but most everything is in the book that you can see. We'll start by talking about pneumonia, then move on to UTIs, CNS infections, skin and soft tissue infections, osteomyelitis, intra-abdominal infections, endocarditis. I'll talk a little bit about C. diff, and then we'll finish up with surgical prophylaxis. So we're going to start with pneumonia, and the first case is located actually on page 7. Oh, and just to mention, as with yesterday afternoon on my slides, the page number that I'm on in the chapter is at the bottom of the screen. And if I'm talking about a particular case, the answer will be in parentheses as well, the page with the answer on it, if you want to flip to the answer at that particular point. So this is on page 7, RL. RL is a 68-year-old male. He presents to the emergency department with cough and shortness of breath. His symptoms began 4 days ago, and they've been worsening over the past 24 hours. He's now coughing up yellowish-green sputum and complains of chills with a fever as high as 102.4 Fahrenheit. His past medical history includes coronary artery disease, including an MI 5 years ago, CHF, hypertension, and osteoarthritis. He rarely drinks alcohol, and he quit smoking when he had the MI 5 years ago. Meds on admission include lisinopril, Tenaday, hydrochlorothiazide, and acetaminophen. Right now he's alert and oriented, not confused. His temperature is 101.8, heart rate is 100, respiratory rate 24, and his blood pressure is 142/94. Labs are all normal except his BUN is 32 and his serum creatinine is 1.23. His blood gases are pH of 7.44, PCO2 of 35, PO2 of 82, and his O2 sat on room air is 90%. And a sputum specimen at this point is not available. So I want to flip back before we get into the specific question for that particular case. Flip back to page 4 and 5. I have the symptoms there for community-acquired pneumonia. RL is experiencing a number of those, including a cough that's productive with sputum, shortness of breath, chills, and fever. He does have somewhat of a potential complicated course, and it's recommended that whenever you are presented with a patient with community-acquired pneumonia, you use some sort of scoring system to decide where the patient should go for treatment, whether that's home or hospital or within the hospital, whether that's a general ward or an ICU. So there's port scoring system, which I refer to in the handout on page 5. What's more commonly used is the CURB 65 score, which again I have on page 5, tables 1 and 2. That goes over how to calculate a CURB score and then also how that should then manifest as far as a location of treatment is concerned. So if you look in this particular patient, his CURB score is 2. He has an elevated BUN or urea, and on the handout I notice I put that in SI units, millimole units. You're probably more familiar with the milligrams per deciliter, and for that it's anything greater than 19. So his BUN at this point is greater than 19, so he gets 1 point for that, and his age is over 65. So his CURB 65 score is 2, and so if you look at location of treatment and risk of death, location should be either outpatient or inpatient, because this patient has a number of comorbidities. More than likely he should be treated as an inpatient. Most common organisms with CAP are strep pneumonia, mycoplasma pneumonia, and H. influenza. So what is the best empiric therapy for RL? And hopefully, again, you brought your cards and you can flash your cards so I can sort of see where you're at in regard to the answers to these questions. Ampicillin sulbactam, 1.5 grams every 6. Piperacillin tazobactam, 4.5 every 6 plus gentamicin. Ceftriaxone 1 gram once a day and azithromycin 500 once a day, or doxycycline alone. Okay, good. All right, you guys know your CAP. Whenever you're faced with a CAP patient, you should go through some sort of algorithm in your head to figure out what they should receive. And the first sort of fork in the road on that particular algorithm is whether you're going to treat as an outpatient or an inpatient. So I'm going to start going over recommendations for outpatient. So if you're going to treat as an outpatient, then there's another fork in the road on the algorithm, and you have to look at whether they're healthy and whether they've had antibiotics within the past 3 months. So if they're previously healthy and no antibiotics in the past 3 months, then the recommendation is a macrolide alone or doxycycline alone. And the macrolide to use is usually recommended to be either clarithromycin or azithromycin. Now, the other option on that particular algorithm is if they're not healthy, if they have comorbidities, or if they've had antibiotics in the past 3 months. And if that's the situation, then the recommendation is a fluoroquinolone alone, or a macrolide with high-dose amoxicillin, with amoxicillin clavulanate, or with either an oral or an IV cephalosporin. Now, the other, if we go back up the algorithm, so the other option would be that you're going to treat as an inpatient. So what I just talked about was treating as an outpatient. If you're going to treat as an inpatient, then again, there's another sort of fork in the road on that particular algorithm that you can look at. If it's a moderately severe infection, and this would be a patient who needs to be hospitalized, but they don't need to go into the ICU, the recommendation is either a fluoroquinolone alone, or a macrolide plus a third-generation cephalosporin, most people would use ceftriaxone, or a macrolide plus ampicillin, or a macrolide plus ertapenem. So a macrolide plus one of those beta-lactams, or a fluoroquinolone alone. That's the options for someone who is going to be treated as an inpatient, moderately severe, but will be treated on a regular floor, a general ward. Now, the other option is if it's severe and you believe the patient needs to go into the ICU. And if that's the situation, then the recommendation is ampicillin sulbactam plus a respiratory fluoroquinolone or azithromycin. So ampicillin sulbactam plus, let's say, levofloxacin, or ampicillin sulbactam plus azithromycin. Or you could use a third-generation cephalosporin plus either of those two that I just mentioned. And if you believe that the patient might have an MRSA pneumonia, maybe a Pseudomonas pneumonia, which are not going to be as common, but in certain patients with certain risk factors that could occur, then you might need to broaden your antibacterial activity. And I've listed there for MRSA, and it's also in your handout, those situations where you really might want to consider having an antibiotic that has MRSA activity. So if the patient is going into the ICU because they're obviously very sick and you want to make sure you have adequate antibacterial activity, if they have necrotizing infiltrates, that's very pathognomonic for MRSA, or if they have an empyema. So, which is the best empiric therapy for RL? And I think most of you picked this up. We're going to treat them as an inpatient, so the best therapy would be C, ceftriaxone plus azithromycin. All right, moving to the next case, and also to nosocomial pneumonia now. This is BP. BP is a 66-year-old female, and she had a cabbage times 2, so a 2-vessel cabbage 8 days ago. She's now on a ventilator in the ICU. She is spiking temperatures, and a tracheal aspirate shows she has many white cells on that tracheal aspirate and gram-negative, and she's growing gram-negative rods. She has a past medical history of coronary artery disease with an MI 2 years ago, COPD, and hypertension. So the question is, in this particular patient, what is the best empiric therapy for BP? Ceftriaxone plus gentamicin plus linezolid, piperacillin tazobactam alone, levofloxacin plus linezolid, or cefepime plus tobramycin plus vancomycin. All right. Correct answers. So let's talk about nosocomial, and then you'll come back, and hopefully that answer will be self-evident when we get back to that question again. So when we talk about nosocomial pneumonia, there's three types. There's hospital-acquired pneumonia, ventilator-associated pneumonia, and healthcare-associated pneumonia, all of which are defined in your chapter. You're going to have to flip back for those definitions, but they're at the bottom of page 5. Now, when you look at a patient with nosocomial pneumonia, there's obviously certain risk factors. The risk factors in BP include the fact that she's mechanically ventilated, and we have decreased the risk a lot by doing various things when patients are mechanically ventilated, like keeping the head of bed at 30 to 45 degrees and making sure that you have good mouth care, et cetera. So there's things that we can help to decrease that incidence, but it's still obviously a risk factor. The recent surgery is a risk factor, the fact that she's in the ICU, that she's older, and the underlying chronic lung disease, the fact that she has COPD. And as opposed to the organisms in CAP, the organisms in nosocomial pneumonia are primarily gram-negative organisms and Staph aureus. In fact, the 1-2 organisms are Pseudomonas and MRSA. So those are always the organisms that have to be at the forefront of your thinking when you're thinking about antibiotic therapy for those patients. Now, there are certain things that you also need to assess when you're looking at your patient in order to figure out whether they're at risk of having a multi-drug resistant organism. And those are listed, again, in your handout on the bottom of page 8, and they're on the screen now. So any antibiotic therapy within the last 90 days, if they've been in the hospital for 5 or more days, if there's a high resistance in the community or the hospital unit that the patient is in, if they have risk factors for healthcare-associated pneumonia. So when we talk about the definition of healthcare-associated pneumonia, there's various risk factors, and those are, like I mentioned, on page 5. But they include recent hospitalization within the past 90 days, nursing home, so someone coming from a nursing home, anyone who's had home care or home infusion, anyone on chronic dialysis, or a family member with multi-drug-resistant organisms. And then finally, a patient who has an immunosuppressive disease and or is on immunosuppressive therapy. Now, as with community-acquired pneumonia, when you're faced with a nosocomial pneumonia patient, you need to also run through an algorithm in your head. And the first step in that particular algorithm is whether the patient, this is an early onset with no risk factors for MDR, for multi-drug-resistant organisms, or whether it's a later onset or the patient does have risk factors for multi-drug-resistant organisms. So the first setting then, treatment for early onset with no risk factors for MDR. Now this is not a very common demographic because remember, any early onset is less than 5 days. And if it's within the first 48 hours of hospitalization, that's still considered community-acquired pneumonia. So day 1 and 2 of hospitalization are community-acquired, and day 5 is late onset. So this is a patient who acquires pneumonia on day 3 or 4 of hospitalization. Not a common demographic, but I usually see a patient maybe 1 or 2 a month that falls into this particular category. So it does happen, but it's not the most common demographic. And then the patient also cannot have those risk factors for multi-drug-resistant organisms. Remember recent hospitalization, recent antibiotics, coming from a nursing home, et cetera. So if you're in this early onset part of the algorithm, then the recommendations are single drug therapy with either a third generation, usually ceftriaxone, a fluoroquinolone, and I've listed the ones that are recommended there, levo, moxi, or cipro, ampicillin, sulbactam, or ertapenem. So one of those 4 options alone for treating the pneumonia. Now, if you're down the other branch of the algorithm for nosocomial pneumonia, you're in that late onset, or you have risk factors for multi-drug-resistant organisms, and this is by far the more common side of the algorithm, then the recommendation is for a beta-lactam with anti-pseudomonal activity. So this first example here is the cephalosporin, so either ceftazidime or cefepime, plus either an aminoglycoside or a fluoroquinolone. So a beta-lactam, which works on cell walls, plus an agent that's going to work within the nucleus, either aminoglycoside or a fluoroquinolone. Now you can use a different anti-pseudomonal beta-lactam, like a carbapenem, either imipenem or meropenem or doripenem, plus again either an aminoglycoside or a fluoroquinolone. Or finally, piperacillin, tazobactam, and anti-pseudomonal penicillin, plus either aminoglycoside or fluoroquinolone. So one of those particular combinations needs to be used. And basically, you have to look at your patient and decide what's going to be best for your patient. There might be issues with resistance with one of the agents that you don't want to use it, or maybe the patient has really bad renal function and you don't want to give them an aminoglycoside or whatever. But you're going to have to then pick the best combination based on the patient that you're treating. Now, it's also recommended that you have an agent that is active against MRSA. Remember, I said MRSA is one of the top 2 organisms in this particular type of pneumonia. And so the recommendation is either vancomycin or linezolid. And whether to use an MRSA, the information there is located in your handout, but basically anyone with a history or recent hospitalization or a presence of devices, and most of your patients, especially if they're mechanically ventilated, they're going to have healthcare devices like central lines, et cetera. Or if there's a high incidence locally. And I know we frequently have people from outside the U.S. and Canada, but anyone in the U.S. and Canada, you are in a high incidence locally. Pretty much everywhere is, and most places are around 50%. So most of you are going to be greater than 10 to 15%, and I'd be highly surprised if any of the institutions, unless you're outside the U.S., any of the institutions here have a rate that's less than 10 to 15%. So which is the best empiric therapy? Empiric therapy for BP, well, again, 2 agents that have anti-pseudomonal activity. So that really cuts out A, B, and C, because ceftriaxone doesn't have anti-pseudomonal activity, and B and C, there's only one agent with anti-pseudomonal activity. And so basically, the correct answer is D, where you have 2 agents with anti-pseudomonal activity and then vancomycin. All right, question 4 then is moving on to vaccinations, or question 3, sorry, is moving on to vaccinations. BP eventually improves and is transferred to a regular floor, and she cannot remember receiving any recent vaccinations. So which is the best vaccination recommendation for this patient? A, she doesn't need any vaccinations. B, she should receive pneumococcal now and influenza in the fall. C, she should receive influenza in the fall, but because she had the infection, she no longer needs a pneumococcal vaccine. Or D, she should receive pneumococcal now, but the influenza vaccine is not needed in this patient. All right, most of you should be on top of your vaccines. So I'm not going to spend a lot of time with that. There's a lot of information on influenza, which you can see in your book, that talks about how to differentiate influenza from a cold, a little bit about a pathophysiology, and then information on page 10 and 11 regarding prevention and therapy of influenza. The vaccine information is on page 11. It's now recommended that these patients should receive a vaccine, anyone at 65 and older, or those with chronic diseases that are younger than that. Any adult who's a smoker or who has a history of asthma, any living in special environments, and I have those listed a little more, I believe, in the handout, and then immunocompromised patients and patients without a spleen. You see there I have information on both Pneumovax and Prevnar 13. Prevnar 13 is now recommended in all immunocompromised patients in addition to Pneumovax, or patients who are asplenic, again, in addition to Pneumovax. In the other areas, we're sort of in a period now where we're going back and forth with not back and forth, but the decision about whether to move from Pneumovax to Prevnar 13 has not been made yet, but I assume within the relatively near future that Prevnar 13 will probably be recommended in everyone on top of Pneumovax, and potentially in the future instead of Pneumovax, but again, studies need to be done to see if that's the correct recommendation. But for the exam, these are the recommendations at this point in time. And influenza, I'm sure you're aware, is recommended in any patient 6 months of age and older. There are some new influenza products coming out that have been out, and newer ones that are coming out. FluMist has been out a while. That's the live attenuated influenza vaccine recommended in otherwise healthy patients between the age of 2 and 49. And then there's also now a high-dose inactivated influenza vaccine, high-dose Fluzone, which is indicated in those over the age of 64. The CDC has not come out with a preference of that over the regular flu vaccine for that age group. Studies are ongoing, and until the results of those studies come out, that recommendation won't be made. There will be quadrivalent vaccines available in the fall as well. So if you're going to use the inactivated or the live attenuated, you'll have the option of a quadrivalent, which has 2 A's and 2 B's instead of just 2 A's and 1 B. And that'll be available in the fall. And again, the CDC is not saying one is preferred over the other at this point until studies tell us whether one is more advantageous than the other. So the correct answer for this one for BP would be B. She should receive the pneumococcal vaccine now. She has disease state risk factors, and she also is at risk because of age, and then she should receive the influenza vaccine in the fall. All right, moving on now to urinary tract infections, which start in the middle of page 12, and the case number 4 is on the middle of page 13, GN. GN is a 62-year-old female who presents to your clinic with a 3-day history of urinary frequency and dysuria. And during the past 24 hours, she's also had nausea, vomiting, and flank pain. She has a past medical history of type 2 diabetes, hypertension, and multiple DVTs. On admission and coming to the clinic, she had meds on admission include glyburide, enalapril, warfarin, and metoclopramide. As far as her physical exam is concerned, she's alert and oriented. Her temperature is 102.8, heart rate is 120, respiratory rate 16, and she's a little orthostatic. The labs are pretty much normal, except her INR is 2.7. She's on warfarin. BUN is 26, serum creatinine 1.88, and the white count is 12. A UA is performed, and it's shown to be turbid, have glucose in there, pH of 7, protein of 100. Some of those things more specific for her diabetes than the urinary tract infection. But she does have white cells, 50 to 100, positive nitrates, 3 to 5 red cells, bacteria, and casts. So a number of things there that would tip you off to the fact that she has a urinary tract infection, including the white cells, positive nitrites, bacteria, and casts. So how should GN be treated? Trimethoprim sulfa DS, BID for 7 days, ciprofloxacin IV BID, and then switch to oral for a total of 10 days, gentamicin once daily for 3 days, or tigecycline 50 Q12 followed by doxy, again to complete a 10-day course. All right. Some mixing of answers, some people not so sure. So let's talk about UTIs and how we treat UTIs. The first information has to do with community, the organisms involved in community-acquired UTIs. And you can see in this pie graph that by far the most common organism is E. coli, and then other gram-negatives including Proteus and Klebsiella, followed by Enterococcus and Staph saprophyticus. It's a little different pattern if we look at nosocomial UTIs. Again, E. coli is a very common cause, accounting for about a third of the cases. But now you have even more gram-negatives, including Pseudomonas, again, Klebsiella, Proteus, Staph aureus can occur, as well as Enterococcus, and then other organisms are just sort of mixed in there as well. So a little different pattern when you're talking about a nosocomial UTI. Now, GN has a number of risk factors, and I do have risk factors that are listed on the bottom of page 12 and then the top of page 13. She has risk factors including age, female sex, and diabetes. And always when we're looking at a UTI patient, again, when you're faced with a UTI patient, you have to think, is this cystitis or pyelonephritis? And cystitis is more of a local infection that includes dysuria, frequency, and urgency, so local symptoms related to the bladder, versus pyelonephritis, which tends to be more of a systemic infection. So you still have the dysuria, the frequency, the urgency, but then you have more systemic symptoms as well that include nausea, vomiting, flank pain, fever, increased white cells, etc., casts on the UA. So we can see from GN, because of all the symptoms that she has a pyelonephritis. Now, we also then, when we're faced with a UTI patient, we need to know if it's cystitis or pyelo, but we also need to know if it's complicated or uncomplicated. And the factors that are associated with a complicated UTI are at the bottom of page 13, and they spill over into the top of page 14. And I've listed all of them here. There's quite a bit. Any male with a UTI, hospital-acquired pregnancy, anatomic abnormalities, indwelling catheters, etc., and you can read through those on your own. And so again, if we look at GN, who we now know has a pyelonephritis, we also see that she has risk factors for a complicated UTI because she has diabetes. So in this patient, it's a complicated pyelonephritis. So we've defined the UTI, and that will help us when we look at therapy. So let's look at therapy. We're going to start then with uncomplicated cystitis. So this is the most simple case of a UTI. The recommended drugs for this are trimethoprim sulfa, nitrofurantoin, or fosfomycin. And the treatment duration depends on which agent you choose. So if you choose trimethoprim sulfa, you're going to treat for 3 days, nitrofurantoin for 5, and fosfomycin for just 1 dose. There are alternatives. You can use either a fluoroquinolone or a beta-lactam, but these are not recommended first-line agents. So fluoroquinolone is not a recommended first-line agent. The agents that are recommended are those 3. And a lot of the reason the fluoroquinolones are no longer recommended is because of overuse and resistance with E. coli. Now we're going to move from uncomplicated cystitis to uncomplicated pyelonephritis. So in an uncomplicated pyelonephritis, then, the options are fluoroquinolone, trimethoprim sulfa, or a beta-lactam. And you can see with the pyelonephritis, one of the big things is the difference in the agents that we have to choose from. No longer is nitrofurantoin or fosfomycin an option. And then the length of therapy, you see, goes from anywhere from 5 to 14 days. And 5-day therapy has been shown to be appropriate for fluoroquinolone, but for trimethoprim sulfa and beta-lactam, the data is not there for a shorter course therapy, unfortunately. So the recommended days of therapy for pyelonephritis are longer with those agents. Also, if uropathogen resistance, in other words, E. coli, is greater than 10% in your particular site, then they recommend that you give an initial dose of a long-acting beta-lactam or a once-daily aminoglycoside. So give 1 dose of, say, ceftriaxone, or 1 dose of high dose, like 5 mg per kg gentamicin, and then you can treat with the agents that are listed there. And that's because there is a concern that if you do have a high rate of, let's say, E. coli resistant to levaquin or to fluoroquinolone, and you put the patient on a fluoroquinolone, that you might have failures in that regard. But that 1 dose potentially could help decrease those failures. Now with complicated UTIs, and these are sort of lumped together, either complicated cystitis or complicated pyelonephritis, the recommended drugs are close to what they were for an uncomplicated pyelo, but you can see there's no trimethoprim sulfa. Now the only options are fluoroquinolones, aminoglycosides, or an extended spectrum beta-lactam. And the recommended duration is, again, 5 to 14 days, with the 5-day data primarily with fluoroquinolones, not with the other agents, not with the older agents, because those studies just haven't been done. In pregnancy, the recommended agents are either amoxicillin, nitrofurantoin, or cephalexin, and the treatment duration is 7 days. So our patient is GN, so look at those potential options, and I'm going to go back to the question in just a bit and look at the length of therapy. And now let's go back to that particular question. So how should GN be treated? Trimethoprim sulfa BID for 7 days, Cipro IV followed by oral for 10 days, gentamicin for 3 days, or tigecycline followed by doxycycline. So now you should be able to figure out that the correct answer is B, Cipro for 10 days. Gentamicin could be used, however, it's not a long enough course. It's only a 3-day course. And then the tetracyclines are not recommended, and trimethoprim sulfa is not recommended. All right, I do have information on catheter-related UTIs, on prostatitis and epididymitis, and so you can read through those. Those are things maybe you won't have as much experience with, so make sure you do take an overview of those particular disease states, because there could be questions on the board on the exam regarding those. All right, moving on to skin and soft tissue infections. Skin and soft tissue infections can be divided into 3 types: acute cellulitis, erysipelas, and necrotizing fasciitis. And I have each of those in your handout on page 16 and 17. So you can read through those. I don't have any cases for those. And then I also have information on the shingles vaccine thrown in there, because there's no other ways where, I don't think, in the prep course where you get information on Zostavax. And because you're preventing something that happens on the skin, I thought I'd put it in the skin section. So let's now move to diabetic foot infections, which is in the bottom of page 17, and the case is number 5 on page 17. It's still GN, same patient we had before. She returns to the clinic in 6 months with no urinary symptoms, but now her chief concern is that she has an ulcer on her right foot. She was on vacation. She thinks she stepped on something while she was walking barefoot on the beach. Her foot is not sore, but it's red and swollen, and she has a little bit of an ulcer. The ulcer is deep, and the infection may involve the underlying bone. Her medications are the same as they were before. Her vital signs are stable. So the question is, which organisms are responsible for diabetic foot infections? Strep pyogenes, Pseudomonas aeruginosa, Staph aureus, or they're polymicrobial with gram-positives, negatives, and anaerobes. All right, that's a pretty straightforward question, hopefully. So there's a lot of things that put patients with diabetes at risk for diabetic foot infections. Those include the neuropathies, vasculopathies, and immunologic defects that occur over time with someone who has uncontrolled diabetes. And all of those things increase your risk of a diabetic foot infection. They are generally polymicrobial with potential for gram-positive, gram-negatives, and anaerobes. And there's a lot of things patients can do if they have diabetes to help prevent these infections, including those things listed there and on page 18 in your handout. So the correct answer is D. Now moving to question 6, which is the best empiric therapy for GN? Nafcillin alone every 6 hours for 6 to 12 weeks, tobramycin plus levofloxacin for 1 to 2 weeks, ampicillin sulbactam for 2 to 3 weeks, or a below-the-knee amputation followed by ceftriaxone for a week. Good. So let's go through treatment. Hopefully we won't have to go to D, but it does happen. The recommendations for treating diabetic foot infections were relatively recently updated. And they divide diabetic foot infections into 2 types. So again, when you're faced with your diabetic foot infection, you can sort of have an algorithm in your head and figure out, is this a mild to moderate infection, or is this a more severe infection? A mild to moderate infection would be one where you don't have much of an ulcer, it's not very deep. You're probably not going to see this patient in the hospital that much, but if you work in a clinic somewhere, then you're going to see these patients come into the clinic. And it's more or less like a cellulitis, and because of that, we treat like a cellulitis. If they have risk factors for MRSA, then you can use doxycycline or trimethoprim sulfa, but otherwise use things like you would for a cellulitis. So dicloxacillin or Keflex or something along that line like you normally would to treat a cellulitis. Now if they're more severe, and if it's a patient who's hospitalized, generally it's going to be more of a severe infection, then you need to broaden your activity because now you're probably dealing with gram-negatives, gram-positives, and anaerobes as well. And then if the patient has risk factors, you might also have to add agents that have activity against MRSA or Pseudomonas. And the recommended antibiotics you can see there on page 18 in your handout: ampisulbactam, erdaperidone, cefotaxime, a third-generation cephalosporin, fluoroquinolones, etc. And then the duration for a mild to moderate infection is a couple weeks, 1 to 2 weeks. For severe infections, 2 to 3 weeks. And then if the infection has gone deep enough where it's now affecting the bone, you're going to have to go even longer than that, greater than 4 weeks, sometimes 6 weeks, 8 weeks, however long that's necessary. And frequently, for those patients, they cannot be adequately treated simply because they do not have good enough blood flow to the particular site, and so they do end up getting amputations. And patients with diabetes are by far the biggest risk group for lower extremity amputations, which is surgical therapy. So, what is the best empiric therapy for GN? That would be C, ampicillin sulbactam. Nafcillin alone, this is more than a mild to moderate. You could use that for a mild diabetic foot infection. Tobra and levofloxacin have no anaerobic activity, and you might also want to be a little careful with the Tobra in this patient with diabetes. And then, again, medical therapy is usually first line or tried before you move on to more surgical therapy like below-the-knee amputations, or amputations in general. All right, osteomyelitis, starting on page 19, WA. WA is a 55-year-old male who presents with weight loss, malaise, and severe back pain and spasms that have progressed during the past 2 months, and he's also now experiencing a loss of sensation in his lower extremities. 4 months before this particular admission, he had surgery for a fractured tibia, and he had a subsequent infection after that. And he also has hypertension and diverticulitis. He's alert and oriented. Temperature is not elevated that much. Heart rate of 88, and blood pressure looks fine. Labs are within normal limits. His white count is 14.3. His SED rate and CRP are both elevated. An MRI is done of his back, which shows bony destruction of L1 and L2, and that is also confirmed by a bone scan. And a CT-guided bone biopsy is now growing gram-positive cocci and clusters from his lumbar vertebra. So, how should WA be treated for this osteomyelitis? Vancomycin with a total duration of 6 weeks, nafcillin with a total duration of 2 weeks, levofloxacin with a total duration of 6 weeks, or Unison with a total duration of 2 weeks. All right. So let's go through osteomyelitis, and then we'll come back to the question, and hopefully by that point you'll be able to answer it quite well. So there's 3 main types of osteomyelitis, and you probably notice I love categorizing things. So if you can categorize the 3 types, hematogenous, contiguous, and then vascular insufficiency, which we already sort of talked about when we talked about diabetic foot infections. So hematogenous is primarily in children, although you do see it in adults with vertebral osteomyelitis, like WA. There are certain risk factors like bacteremia, so remember WA had an infection a few months ago where he potentially or probably was bacteremic. And then the organisms you can see are primarily Staph aureus. Sickle cell patients have slightly different organism patterns, as do IV drug abusers have slightly different organisms. Now, a contiguous spread is when you have an infection that's close to a bone and then it spreads to the bone. Again, primarily in adults. Risk factors include open reduction, internal fixation of broken bones, gunshot wounds, soft tissue infections, etc. Usually these organisms are more mixed, and you can have both gram-positive and some gram-negatives, and occasionally anaerobes as well, depending on what was in the initial infection. And then finally, vascular insufficiency, which is primarily diabetic patients, but also patients with peripheral vascular disease who don't have good blood supply to their lower extremities. So, WA's presentations and clinical findings, he had the risk factors, he has the signs and symptoms, the lower back pain, the loss of sensation, and his labs, elevated white count ESR and CRP, and then the MRI, which is the gold standard for diagnosing, and then you can do bone scans as well. So the recommended therapy then depends on age, and you can see there I've had for pediatric patients, you can see the antibiotics that are recommended. Staph aureus is very common, and so you see a lot of agents that are specific for Staph aureus. In adults, the recommendation is, again, something that has activity against Staph aureus, nafcillin or cefazolin, or if you think it's going to be MRSA, vancomycin. And then, again, based on patient-specific characteristics, you can make alterations. And then sickle cell patients or patients with prosthetic joints also have differing recommendations as far as antibiotics are concerned. Now, osteomyelitis has to be treated for a long period of time. The vessels that feed the bone are very small. When they enter the bone, they make a lot of hairpin turns, so blood flow is somewhat limited, and therefore getting adequate antibiotics to the site of the infection is decreased, and therefore you have to treat for a long period of time. So for acute osteomyelitis, at least 4 weeks of therapy, and most people would recommend more like 6 weeks of therapy. And with chronic osteomyelitis, usually a couple months of therapy, and then sometimes you even have to follow that up with more suppressive therapy even after that. So the answer now should be, should be self-evident. Obviously, you don't want to use levofloxacin, not that great activity against Staph aureus. Ampicillin sulbactam could be used, however, the duration is not long enough, same thing with nafcillin, so the correct answer is A, vancomycin for a period of 6 weeks. And again, if you do end up culturing the organism, you can, as with all these questions, you can change the antibiotics to more fit whatever culture results you find. All right, now CNS infections and DM. DM is a 21-year-old university student who presents to the emergency department with the worst headache of his life. During the past few days, he's felt slightly ill, but he's still been able to go to class regularly and eat and drink okay, but this morning he awoke with a terrible headache and pain whenever he moved his neck. He has no real past medical history. His pain is a 10 out of 10. Temperature is elevated at 102.4. Heart rate is up. Blood pressure is okay at this point. His white count is elevated to 22.5 with a shift to the left. An LP is done, and within his CSF, his glucose is decreased, his protein is increased, and he has 800 white cells. And that gram stain of the LP shows abundant gram-negative cocci. So, if you're looking at meningitis, the organisms are relatively limited, but they change a little bit depending on the age. So the most common organisms are strep pneumo, Neisseria meningitis, and H. flu, with an occasional group B strep or listeria thrown in there in certain age groups. And then less common organisms you can see there on the right. Now, DM fits the classic presentation for meningitis, including the fever, the headache, and the nuchal rigidity, where he has pain anytime he moves his neck. And then his CSF also is classic for meningitis, a decreased glucose, and you always have to compare your CSF glucose to your serum glucose. And it's usually normally about 2/3 of peripheral, but in meningitis it goes down. And then protein is generally elevated in meningitis, and you shouldn't have any white cells normally in your CSF, and generally they're quite elevated in meningitis. So he fits that pattern. You should always do a gram stain, obviously, with CSF samples, and you can also do latex agglutination. Some institutions do that, especially in kids. Others do not. And all of the lab findings, you can see there, he had an increased white cell count with a left shift, positive gram stain, positive CSF cultures. So how should DM be treated? With penicillin plus dexamethasone, ceftriaxone alone, ceftriaxone plus dexamethasone, or ceftriaxone plus vancomycin. Okay, good. And there actually might be a couple of correct answers here, which most people are getting both of those correct answers. So with neonates, because of the risk of listeria and group B strep, the recommended antibiotics are AMP plus aminoglycoside or AMP plus cefotaxime. With infants, third-generation cephalosporin, which is the gold standard of treatment, usually ceftriaxone plus vancomycin. Pediatrics and adults, the same thing, a third-generation cephalosporin plus vancomycin. The vancomycin is there in case of resistant strep pneumo. So if you have highly resistant strep pneumo, obviously ceftriaxone is not going to be active, and so that's why the vancomycin is there until you get culture results back. And then older adults, again, we add ampicillin again because of the risk of listeria. And then more antibiotics if you have other risk factors. So therapy of specific pathogens is listed in your handout, and I'm not going to go over that specifically, but you can see specific therapy for strep pneumo, Neisseria meningitis, and H. flu, and then a few other antibiotics or organisms as well, including listeria. Length of therapy depends on the organism. Generally, the more severe organisms have lower lengths of therapy. So Neisseria meningitis, which tends to kill you very quickly, you really only have to treat, though, for 7 days. H. flu, which we don't see much of anymore, but it can occur, 7 days, and then strep pneumo is a 10 to 14-day course. Now, whether or not to use steroids depends on the organism and the age. So there are certain risks versus benefits. The benefits are that there is less hearing loss in children with H. flu, and there's improved outcomes in adults with strep pneumo. However, there are potential risks, including decreasing inflammation, decreasing penetration of antibiotic into the CNS. So the recommendation is that you give either right before or with the first dose of antibiotics, and the recommended agent is dexamethasone for 2 to 4 days. And that's used where they have seen benefits. So we use it in kids with H. flu, meningitis, which doesn't really happen anymore because of the vaccine, and then adults with strep pneumo meningitis. So the correct answer, because this patient has gram-negative cocci, which are going to be Neisseria and not strep pneumo, you really don't need dexamethasone. You could include vancomycin until the culture results come back, because potentially it could be strep pneumo, but it's highly likely that it's Neisseria, in which case you wouldn't need vancomycin. So I have the correct answer as B, and if you consider D, that you could argue that as well, that would be a correct answer. All right, moving on now to question 9 now. Following the diagnosis, there is concern about prophylaxis. Who should receive prophylaxis that had exposure to DM? So which of these is the best recommendation? Healthcare providers with close contact should receive rifampin, 600 every 12 for 4 doses. Those that lived with him in the dorm and were in the same classes with him should receive rifampin daily for 4 days. Those in the emergency department everyone in the emergency department should receive the meningococcal vaccine, or those in the emergency department should receive rifampin every 12 hours for 4 doses. So answers to that. This always comes up a lot. Okay, so let's go over that real quickly. This is chemoprophylaxis. It's for close contacts only. That would be people who live in the same household. So it wouldn't be everyone in the dorm that he lived in, but his roommates, people who had close contact with him, should receive it, or daycare, anyone in the same daycare. And exposure to oral secretion. So that wouldn't be everyone in the emergency department, but if you had people who were in the same room or had very close contact with him, they should receive chemoprophylaxis. For Neisseria, it's BID for 4 doses. With rifampin. And just information on the meningococcal vaccine, it's obviously recommended now for all adolescents, so hopefully the incidence in college campuses will start to go down dramatically. And then there's other patients which are listed there who should also receive the meningococcal vaccines. And then there's a recommended booster 5 years for adolescents, 5 years after they receive their first meningococcal vaccine, and then for asplenic patients after 2 months, and then every 5 years for the rest of their life. So the correct answer for this would be A. And recommendations for H. flu, which again we don't see that much anymore, are also in your handout on the bottom of page 25. All right, moving on now. Endocarditis. This is TS. TS is a 48-year-old male, and this particular case is at the bottom of page 26. He presents to the emergency department with fever, chills, nausea, vomiting, anorexia, lymphangitis in his right hand and lower back pain. He really doesn't have any past medical history, just kidney stones 4 years ago. He is homeless and an IV drug user for the past year, but he quit 2 weeks ago. He's on the right track. So he's alert and oriented. His temperature is 100.8, heart rate elevated 114. He has a systolic ejection murmur, and his right hand is erythematous and swollen. His labs are within normal limits. He's HIV negative. A blood culture is done. Multiple blood cultures are done that grow MSSA. 2 more cultures are drawn, and now they're growing gram-positive cocci clusters, probably also the same organism, MSSA. A transesophageal echo is completed that shows a vegetation on his mitral valve. How should TS be managed? Nafcillin for 2 weeks, nafcillin plus rifampin for 6 weeks, nafcillin plus gent for 2 weeks, or nafcillin for 6 weeks with gent for the first 3 to 5 days. All right, so TS has a number of clinical findings that would make you believe that he has endocarditis. His risk factors are IV drug use, which is a huge risk factor, and then the normal signs of infection. A lot of times with endocarditis, they don't have a lot of things other than the cardinal signs for infection, but you will see the cardiac murmur, and so that's what you're looking, or not looking for, but listening for, is the murmur that would tip you off that this could be endocarditis. And then these patients will have positive blood culture after positive blood culture after positive blood culture because they're constantly spilling organisms into their blood. Now, when you look at an endocarditis patient, you will generally categorize that patient into which organism is causing the endocarditis. And we virtually always have an organism, not always, but most of the time. And the top 3 organisms are streptococci, staphylococci, and enterococci. Now, if you're treating streptococci, the recommended therapy is either Pen-G or ceftriaxone or vancomycin, one of those options. And we treat for 2 to 4 weeks, and if you're not going to use an aminoglycoside in the patient, then you need to treat for the full 4 weeks. But if you use an aminoglycoside in a patient with strep endocarditis, you can decrease that length of therapy down to 2 weeks, and so that's obviously very advantageous in our patients. So here the aminoglycoside is used to decrease the length of therapy. With MSSA endocarditis, then usually a beta-lactam that's active against staph or vancomycin. With MRSA, you're going to need to use either vancomycin or daptomycin. And the treatment is for 6 weeks. And you can use an aminoglycoside in your patients. In this case, the aminoglycoside is used just in the first 3 to 5 days, and it's basically there to decrease the bacterial load, to make the patient feel better, to make the positive blood cultures go away quicker, decrease fever, etc. So it's not necessary. It doesn't decrease the length of therapy, but it's frequently utilized in those first 3 to 5 days to decrease that bacterial load. And then finally, the third most common endocarditis is enterococcal endocarditis. And for this, you need to use either Pen-G or ampicillin plus an aminoglycoside or vancomycin plus an aminoglycoside. Treatment is 4 to 6 weeks, and in this setting, the aminoglycoside is absolutely necessary. You cannot treat with one drug alone. With any systemic enterococcal infection, you need to use 2 agents. And so the aminoglycoside, again, must be there due to inherent resistance in the enterococcus. So the correct answer for TS would be then D, nafcillin for 6 weeks, and then you can add the aminoglycoside for the first 3 to 5 days because this is an MSSA endocarditis. All right, TS has a tooth extraction then 6 months later. Or is going to have a tooth extraction 6 months later. What do you recommend for prophylaxis prior to this procedure? First, tooth extractions do not require prophylaxis. Second, amoxicillin 1 dose 1 hour before the extraction. Third, amoxicillin 3 grams 1 hour before, and then 1.5 grams 6 hours, every 6 hours, for 4 doses after the extraction. Or D, TS does not need any prophylaxis. Okay, good. Good answers coming out. So I do have tables in your handout. The rules for prophylaxis of endocarditis were simplified about 4 or 5 years ago. And so now there are certain situations in which prophylaxis is necessary. And if you look at table 12, those are on the left. So these are looking at the patient. What are the risk factors in the patient that would make it necessary? And you see here that one of the conditions is previous bacterial endocarditis. So TS falls into that. So that means it would be necessary in TS if he is having a procedure that also requires it, and the procedures are on the right there, and you can see any dental procedure that involves gingival tissues or periapical regions, so that is at the bottom of the tooth. So things like cleanings, it wouldn't be necessary. But if you're doing a tooth extraction, a root canal, something along that line, then you would need to use prophylaxis in those situations. And then respiratory tract procedures, you can also read there, require certain antibiotics. And then the recommended antibiotic doses are simply to give a dose, just like all other surgical procedures, before the procedure. You don't have to give anything afterwards. And usually amoxicillin or ampicillin, and if they have allergies, clindamycin or macrolide. So the correct answer then, that he does need it because he's going for a tooth extraction. He has a history of bacterial endocarditis, so he does need prophylaxis, and only one dose, so the correct answer is B. Okay, the next two sections in your handout I don't have any particular case for, so you can read through those on your own. I have information on intra-abdominal infections. Those guidelines were updated relatively recently. Again, they divide their recommendations into, as far as treatment is concerned, into mild to moderate and then high risk or severe. I talk a little bit about primary peritonitis, secondary peritonitis, and then go through the recommended agents to whether it's mild to moderate or whether it's high risk severe. And you can see all those agents listed there, just a boatload. The one thing that I will mention is with high risk severe, they recommend that you have at least one agent that has anti-pseudomonal activity. So if you look through those recommendations there, you'll see that all of the recommendations have an agent that has anti-pseudomonal activity. For mild to moderate, that's not necessary. So basically, you are talking about antibacterial therapy that has activity against gram-negative organisms and anaerobes, because those are the ones that you're going to be faced with most in the gut. Starting on page 31 and going over to page 32, I have information on C. diff, so make sure that you're familiar with C. diff. The risk factors and symptoms are listed there, as well as therapy. It can be either metronidazole, vancomycin, or fidaxomicin for initial episodes and first recurrences. And then for second and third or multiple recurrences, it's sort of like the Wild West. So consider fidaxomicin, higher doses of vanco, maybe use taper therapy, pulse therapy, fecal transplants, a lot of different options you can go through when you start having patients with multiple recurrences. Okay, the last section that I'm going to go over is surgical prophylaxis, and after more than a decade, the surgical prophylaxis guidelines were finally updated a few months ago, and that particular reference is in your handout if you want to look at that, 2013 reference. So not much change, though, even over the decade, but some things, especially dosing, changed a lot, so they're recommending higher doses of cefazolin specifically pre-op for most patients. But as far as the concepts are concerned and the specific antibiotics to use in specific situations, those didn't change a whole lot. So question 12 is that you are a pharmacist who works closely with the surgery department to optimize therapy for your patients, and the surgeons provide you with principles of surgical prophylaxis that they believe are appropriate. Which is the best practice for optimizing surgical prophylaxis? You need to redose antibiotics for procedures longer than 4 hours. Or that involve major blood loss. Give antibiotics for 24 hours after the procedure. This optimizes prophylaxis. Pre-op antibiotics can be given up to 4 hours before the incision. And vancomycin should be the antibiotic of choice due to its half-life and long and activity against MRSA. Okay, so let's go over some concepts in surgical prophylaxis. Surgical procedures can be divided into clean, contaminated, contaminated, and dirty, and most of the time we're dealing with the clean, contaminated, and contaminated infections. Timing is very important. This data is from a study that was done quite a while ago, probably almost 20 years ago, that showed the lowest infection rate you can see there is in those patients who receive their antibiotics within an hour or two prior to the procedure. And ideally, you need to receive the antibiotics within an hour prior to the first cut. This is also infections related to duration. You can see as the duration goes up, your infection rate goes up, and that's why they recommend redosing in patients who go for procedures longer than 4 hours, or if they have major blood loss. And the duration, sorry, I went over that quickly. For most procedures, generally the duration is just the one dose when the patient, right before they get that first cut. Some cardiac procedures, still the recommendations recommend 24 to 48 hours, and some people still go up to 24 hours. That's sort of allowed by SCIP guidelines, but ideally just that one dose prior to the procedure. You really only need activity against skin flora, except for certain colorectal procedures that require more broad spectrum activity. And so the correct answer here, which one of the following is the best practice for optimizing surgical prophylaxis? That would be A. You need to redose antibiotic for procedures longer than 4 hours or those involving major blood loss. I do have recommendations for antibiotics depending on the type of procedure, and you can go through all those and see what they are. Specifically, look at the colorectal recommendations, because those are the ones that are different than most of the other ones are just straight cefazolin or vancomycin, because you're only dealing with skin flora. All right, my time is up. Thank you very much. I'll be up here. I'm talking in 10 minutes at 10:10, but I will be up here to answer questions in this 10-minute period before my next talk. Thank you very much.